Yeah.
Yeah, there were some struggles. All right. So I try to find where the lectures went. All right. So spine and nervous system trauma. Um, so for the most part, falls are the leading causes of spinal injuries, um, primarily over the ages of 45. Under the age of 45, we're still kind of bouncy. Let's go with bouncy, flexible, um, and a little more on the muscular side, which kind of protects the spine. Direct injury to or direct force to the spine is a significant cause of spinal cord injury, um, as well as a variety of other issues and concerns. I had a student once who was a passenger in a van and driving on the Jackie, and a tree fell on the vehicle and crushed him, and kind of ended up with significant spinal trauma secondary to that. Um, so sometimes you don't know when a tree's going to fall on you, but sometimes you also, you know, can do things to help prevent spinal trauma, such as wearing your seatbelt. And that's your public service announcement for the day. Um, Sports are also high on the list, as are, violence, as usual, is always a significant cause of trauma. Uh, the bigger issue with spinal trauma is that it is a very expensive course of action, I guess, or expensive injury, because does it doesn't necessarily cut down on your life expectancy, but it does cut down on your ability to participate in society. It does increase your amount of what's the right word? Medical resources that you do need, right? A lot of people, depending on their age and ability, may require specialty vehicles. They may require specialty lifts in the home. They might require home care, etc. Or if they have no actual support system, they end up requiring, um, a nursing home or something to that effect in order to um, live appropriately. So, just a quick BLS review. You have 33 bones in your spine, 7 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 4 of your coccyx. The sacral and your coccyx are fused together and fused to the pelvis. Um, Fun things that I actually learned recently is that you can actually have what's called a transitional vertebrae, which is when S1 actually becomes L6. It doesn't actually fuse to the pelvis. It becomes an extra lumbar spine, a lumbar vertebrae. So it just kind of increases uh, the what's the word? The potential mobility of the back, because it's not attached to the pelvis. But there are possibilities where part of the sacral vertebrae, that S1, can be fused to one side of the pelvis and not the other. It's a fun little finding that I just found out. Um, each vertebrae is separated by a squishy intervertebral disc. And the intervertebral discs are sort of like shocks for your spine, right? So they provide some sort of cushion. They provide a space so that spinal nerves can escape and innervate the areas appropriately. And they're also the little pedicles, and the little parts, the facets that kind of come off of the spine. Those are connected through ligaments, so it keeps the spine kind of rigid. And it keeps it from just kind of moving all over the place. Interestingly, the adult head weighs anywhere from about 8 to 12 pounds, depending on, your stage in life. That's what I say. We always talk about that big old pumpkin head. So that cervical spine needs to, and the rest of your spine, but primarily your cervical spine, needs to be able to support that amount of weight, and move it around, which is why when we talk about, like vehicle or vehicular accidents, there's such a strain on the cervical spine is because you're throwing a 12-pound bowling ball around on this very narrow kind of support system. The spinal cord itself, what we think of as the spinal cord, where it's like a large fibrous individual, like singular body, actually ends around L1 or L2, depending on how, I guess, tall you are. And then it starts to split into the nerve roots, which is called cauda equina, which is, in not Latin, is horse's tail. Okay, so you have these nerve roots that start to escape from the spine and innervate everything below L1 and L2. So think about, right, your lower back pain, because we all have that lower back pain. Your spinal cord ends right around, if you look at the picture, in between the blue and green. For those of you who are colorblind, you have to actually read the tab, sorry. The spinal nerves that come out from the spinal cord create what's called dermatomes, okay? So dermatomes are these like strips across the body, okay? So like, for example, if you had something up high and it was a dermatome, it would come across the chest like a ribbon, okay? And it kind of wraps all the way around, and that's the area that spinal nerve innervates. So when you have a person who has a spinal cord injury, you can kind of determine where the spinal cord injury originates at based on where they start to lose dermatome sensation. So going back here, if you have C1 through C3, right? Remember the C1, 1, 2, what was it? Nope, totally forgot the little 3, 4, 5 keeps you alive. C3, 4, 5 keeps you alive. Anything above C3 innervates your diaphragm, which will pretty much create a respiratory failure if it is damaged. This is why they called Christopher Reeves actual literal Superman when he broke his neck in that horse accident like a million years ago, was because he actually had a spinal cord injury up at C1, C2, but he was, he lived for many years after that injury. Traditionally, people who have a C1, C2 injury don't have such a fantastic outcome as he did. Not that being a quadriplegic is a fantastic outcome, but it's slightly better than being dead. If you have a spinal cord injury at T4, so hold on, pull the pen up real quick and give a little doodle. So here you got your T4, right? So if you have a spinal cord injury here, it's going to be at the nipple line. The nipples and below is where the patient will be losing their sensation. And come here. And then if you have at T12, right before the cauda equina, you're going to have a patient who has loses innervation at their groin. So if you have a patient also who happens to have a spinal cord injury lower, where it's just affecting the cauda equina, they'll tend to lose sensation primarily only in the groin or the insides of the legs, where T12 might also affect like the outside of the hips, etc. Here you go. Here's another dermatome. T10 is umbilicus. Okay, so if you kind of imagine here, so right, if you have that spinal cord injury at levels of T4, that's kind of where the nipples are. So everything below the site of the injury obviously will be reduced in terms of mobility and sensation. The other issue is that sometimes you might have a patient who has a loss of sensation, but they don't necessarily lose all of their motion. It depends on what part of the spine is injured, because sometimes some of it can actually be preserved. So there's a number of different ways that one can create an injury to the spinal cord. So first off is axial loading, which is a vertical compression of the spine. This is usually when you see patients who have either dove into a shallow pool and hit their head and kind of compressed the vertebrae. Okay, it could be a head against the windshield. It could be another vertical fall. Excuse me. or if you get hit on the head with a heavy object, right? So we had a guy maybe a few months ago who was working, and one of those large industrial air conditioning units actually fell on his head. And it was a concern that he was going to lose some sort of the sensation and such, due to a compression fracture or an axial loading injury. So sometimes you might not actually have a patient who you will be able to see or feel a deformity to, because the vertebrae itself actually just becomes compressed rather than pushing out into a way where you can actually feel it if you actually palpate the spine. So just because you don't necessarily feel a deformity does not necessarily mean that the patient does not have an injury. Other concerns with spinal injury is that you can have a direct blow and then a later onset of paresthesia or inability to move secondary to spinal swelling. So just keep those things in mind. I actually had a patient once who he was working at the airport. He was loading stuff into the plane in between flights, and he stepped back and missed a step and ended up falling flat on his back on one of those like kind of cherry picker loader things. So he had fallen probably about 6 feet. When we got there, he's a-okay, pulse motor sensory times 4. Right before we left, within the 10-minute window, he could no longer move or feel his feet. So spinal swelling can create an issue if you don't reassess your patient, because now spinal swelling can potentially be treated so he doesn't have a long-term neurological issue. But if it's not addressed and you don't make sure that you keep the patient nice and still, you have a potential problem. Other various mechanisms include flexion, hyperextension, and hyperrotation. If anyone has seen Million Dollar Baby, hashtag spoiler alert, towards the end of the movie, she falls and the stool had been pulled out, and she ends up kind of hitting her neck on the stool and creating quadriplegic issues. Sort of the same kind of concept here, at least in the bottom with the hyperextension, right? So you can compress or move your neck in such a way that you either rupture the ligaments or compress the spinal cord, and you can have a dislocation depending on the amount of force that's applied. Hyperrotation is also moving your head too far to one side or the other. Most of these things are caused by acceleration and deceleration forces. The other common, or facial trauma, which is again an acceleration or deceleration issue. The other is hangings, right? So patients who decide to hang themselves will either stretch and or rotate the neck in such a way, depending on where the knot is located. If you ever watch any of those old westerns, the location of where the knot for the hangman's noose is located is kind of important. So if it's off to the side, traditionally those patients would die secondary to strangulation. If it was right in the back, the neck would snap. It would cause enough force to break their neck. So it was a lot more quote unquote humane to hang someone with a knot at the back of their head.
Yeah, so there's like it shows that if you don't do it high enough, then you'll strangle yourself,
Mm-hmm.
as compared to if you do it like past a certain amount, then you completely decapitate the person.
Yep.
There was like supposedly like a whole algorithm that they did based off of weight and height.
Oh, delightful. They do love their science, that's for sure. There's another, we're going to talk about it in facial trauma too, about the pursuit of science. Um, so get excited. It's one of my favorite because the French back in the 1800s, they were crazy. They did some body snatching. They did some wild things to corpses, and we're going to talk about it. Um, Other issues that can cause spinal injury is lateral bending. So this is traditionally like if you get T-boned, right? So your head stays in one place until it gets pulled along. So you see this a lot in not only T-bones, but like patients who are tackled from the side, like in whatchamacallit, football, right? Football injuries. So they'll be standing, they get tackled, their spine goes one way, their head goes the other, and it just creates a shearing, stretching motions that are not great for your spine. Also, the distraction injuries is similar to hangings, right? So, again, talking about, like Rob said, depending on where the knot and the location of the noose is going to create stretching and pull essentially the whole head and stretch the spinal cord. You can also have, we talked about previously, internal decapitations, right? So if you stretch the spinal cord enough, you can actually, create enough space where the spinal cord can actually escape through the side, and will cause all sorts of neurological deficits. But blunt and go ahead. Somebody saying something?
Actually, Nicole, I have a question for you.
Sure.
So Jeffrey Epstein,
Mhm.
you well know, in his prison cell, the autopsy
He didn't
showed.
kill himself.
I'm sorry, what's that?
He didn't kill himself.
Thank you.
Well, I'm asking. My question is this: so the scenario is that he hung himself, but the injuries were to his cricoid thyroid cartilage.
Mhm.
That and so he had a fracture of those bones in the cartilage.
Okay.
I don't know if you're familiar with that or you come across.
So
So it had nothing to do with the cervical spine, but it had to do with.
it was a suffocation. So, however,
Right.
the ligature was placed, and we're gonna do a little CSI stuff here. So, however, the ligature was placed was probably straight across his larynx and his Adam's apple. So.
Right.
Knowing prison cells, there's not exactly an abundance of places that you're going to put a hanging plant, aka your body. So what I'm thinking, and again, we don't have a whole lot of information, but I've seen this done before. It's one of the most effective and popular ways to hang oneself if you don't have a pipe or something, physically up that one can do this, is that you actually take the ligature, you tie it to a spot like the doorknob, and then you just rest your body down. So basically what happens is, as you become hypoxic from the strangulation, you're trying to pull yourself up, but if you measure it just right, you aren't able to get your legs underneath you to push yourself back up, and then you start to you just become unconscious from hypoxia, and then you strangle and die. Which, based on how prison cells are kind of structured, you have that bar in the center where if you put the ligature above that, hang it around your neck, and then sit down, it's kind of the perfect height to accomplish that. And based on the fact that he probably had a thicker ligature, probably a bed sheet, that would explain why the pressure was dispersed across his neck in such a way that you don't see cervical injuries. So it's completely possible that he did create the weight of his body created damage to just the cartilage and the hyoid bone, which is the number one bone broken in strangulation. So it's not 100% impossible that it had happened, but
With the hyoid bone, though, that fracture, does that in and of itself, is that a mortal wound?
no.
Or is it okay? So it's got to be with strangulation attached to it.
Most of the time, yeah. So basically, the entire airway is suspended from your hyoid bone. Your hyoid bone is kind of like up here. So
Right.
any sort of pressure, it's a very thin bone. Think of like a chicken wishbone. It's about that thick. So any sort of pressure is going to create, a fracture, a potential fracture, at the very least a stress compression. So if he was, any sort of pressure across that neck, and as I said, if it's a larger ligature, it could have created like a band all the way across and would have created that damage.
Okay.
So
Thank you.
you're welcome. Any other CSI tips, please let me know. So blunt or penetrating trauma is another significant issue. So when you think of a blunt and penetrating trauma, you think gunshots or stabbing, okay? But you can also have blunt spinal injuries secondary to being hit with a baseball bat or a car, or something like that. Did one of the last medical examiner rotations that they actually allowed. If you see this right here, this X-ray image on the bottom of this picture, where the spinal cord is completely severed, There was a gentleman who was riding his bike. He got hit by a car, and his thoracic, right where the thoracic and the lumbar meet, was completely severed, and it was fully up and into his chest wall. Like, it was just completely severed and up, which was really wild to see after they while they were performing the autopsy.
Why did they stop doing morgue rotations?
Don't know. They stopped it for all paramedic students, so I don't have a good answer for that one. But that was a fun rotation. Yeah, a couple years ago they stopped it for everybody, which is a total bummer. Spinal injury can also be caused by electrical issues, right? If you're electrocuted, that hardcore muscle spasm, you are a lot stronger than you think. You can actually whip your spine right out of alignment if you are electrocuted and have significant muscle spasms. So, different classifications. For the most part, and this is part of the reason that they discontinued, well, among other things, they discontinued the use of long backboards in trauma, was that an unstable spine can in fact be ruled out with a good physical exam. For the most part, a patient is not going to want to move. Your body does this really cool thing called self-splinting. So if you have a patient who is actually experiencing a spinal cord injury, they stay very still. Okay, they don't move their head around. They don't really wiggle all that much, even if they're in excruciating pain, because their body is spasming all around the injury to self-splint, right? And this is part of the reason that we also put splints on, right? Because we don't want to exacerbate the existing injury. So they kind of modified the way that we do immobilization so that we are not unnecessarily putting people on this long backboard. The long backboard was proven to increase the angle of the spine so that it actually worsens spinal injuries. The bed of the stretcher is actually designed to kind of hold the patient in place. Obviously, you're going to have potential issues if you have extremely large obese patients, but for the most part, for the general population, that is the kind of why this is designed this way. And you don't necessarily, like, you'll kind of, for the most part, be able to do a good solid assessment, right? You're going to palpate, you're going to just look at the mechanism of injury. You're going to be on the safe side, put a cervical collar on them and sit them, get them onto the stretcher and, kind of immobilize in that way. A number of other issues that can potentially complicate a spinal assessment is the patient's age, pre-existing bone diseases, and congenital spinal abnormalities. So older and younger patients, right? So younger patients will have a stretchier spinal cord. Those bones are not as solid. They're a little more rubbery, right? So they may not create a significant, obvious injury as an older patient. And you also have younger patients who have an increased ability or increased space for spinal swelling. So any sort of just spinal swelling injuries might take longer for it to be noticeable. Older patients obviously will usually have pre-existing bone diseases because gravity is a bitch, right? As you get older, your bones start to become thinner and less strong. So if you have somebody who has osteoporosis, etc., there's a stronger possibility that they're going to be a lower amount of force is going to be necessary in order to create damage, especially to the spinal cord. Also, for patient age, you have the younger patients who are more willing to take risks, right? Or do stupid things like dive into a pool that's too shallow. And then you have congenital spinal abnormalities such as scoliosis, or patients with Down syndrome, right, who have that shorter neck and have just pre-existing issues in that manner. For the most part, spinal cord neurons do not regenerate. So once it's a significant injury, that's kind of the end of that. There is a permanent loss of function, and the patient will have to deal with those things for the rest of their life. A number of different spinal injuries, and this is going back away not just from actual spinal cord, but all the muscles that are supporting the spinal cord. Sprains and strains, right? So remember, a sprain is an injury to a ligament, where a strain is an injury to a muscle or a tendon. This is usually due to hyperflexion or hyperextension. These are commonly seen in whiplash. Okay, these issues, these injuries. So patients will have, potentially have bad neck pain that kind of goes down into their upper traps because of all the strain of that 8 to 12 pound pumpkin head. Most of the time, these issues can heal, right? But they do need to have a certain level of attention in order to do so. And just because there is a whiplash injury does not necessarily mean that there is not also an underlying spinal or bone injury. We taught this to you guys probably all the way back in BLS. The most frequently injured spinal regions are your cervical and your lumbar, right? Because there's no other supportive bone structures around them. But the most specifically injured are C5 through C7, C1 and C2, which are all the way high up in the neck, and T12 and through L2, okay? Right, because T12 is that last one, that last thoracic vertebrae before it transitions into that lumbar. So that's that pivotal point, right, between where you have something staying still and something wiggling it underneath. A lot of the times the compression fractures, right? So if you have that extra weight or the axial loading or just gravity, if you have any of those things, traditionally the vertebrae goes from being nice and square to being kind of wedge shaped. If you don't know what a wedge shape is, either go look at your closet for shoes that are wedgie shaped or ask your lady friends. Teardrop fractures are also common. If you look here on the side, it's where a part of the vertebral bone actually kind of shears away and looks like a teardrop. Not that you're going to be diagnosing this in the field, but things to know. Sacral and coccyx fractures tend to be common when you land straight on your butt, right? But for the most part, they are relatively well protected by the pelvis and all of the muscles of the lower back and the butt. And yes, I do know there are plenty of people who have no butt muscles, right? They just have a extra back. Those people probably are at increased risk of having coccyx fractures. S1 through S2 usually have a loss of the sensation in the perianal region, or also in the genitalia region. And most of the time these are caused by direct blows or falls. Really falls onto the tush, and those who have not enough padding. Excuse me. So there's two different types of cord injuries that you can experience. One is the primary at the time of impact concern, right? So this is a significant injury, most likely some level of shearing or other damage. And then you have secondary, which is obviously after the initial injury, and it's either due to ischemia to the spinal cord, swelling of the spinal cord, or a bony fragment, or perhaps a bullet fragment, etc., moving and getting itself embedded into the spinal cord. Most of it, obviously, we all understand that if you injure the spinal cord, everything below the injury site or distal to the injury site can have a loss of function, and that loss of function could be either temporary or permanent. Look at that nonsense. That's not a great looking spinal cord anymore. A complete transection is a total absence of everything below the injury. Okay, so that's not, nothing's coming back from that. You're not getting any function or sensation back. And we talked about this last time, the autonomic dysfunction, right? This is when there's some sort of irritant below the site of the injury that creates hypertension above the site and hypotension below the site. Priapism is also an issue. This can happen within the onset of the injury, or it can also happen, years later, just when there's some sort of irritant underneath. Different types of cord lesions are usually dependent on how the spinal cord is affected. C1 through C4 is the tetraplegia, okay? Partial or total loss of movement in all the extremities. May or may not have functional phrenic nerves, depending on how the injury affects the body, which means that they may or may not be event reliant. And these patients require lifelong assistance, right? They are not going to be independent anymore. C5 through 6 is a slightly better situation where they will be able to potentially flex at the elbow or wrist with some limited hand function. So these patients might be able to drive themselves around in a motorized wheelchair. And they obviously will also require assistance. At C7, C8, they will have a little better function at the arms, right? So all the way up to the triceps becomes functional. That's the best word, I guess. These patients may also be able to participate in a little more independent living, but again, it really depends on how well they are able to move themselves around. We keep changing what the word for quadriplegia is. Apparently we're calling it tetraplegia these days. I don't know why. Why not? So as opposed to tetraplegia, where you're losing pretty much all the function below your neck, you have paraplegia also, which could be which is usually below T1. And again, you can have different levels of function in the limbs depending on how much is impacted and I guess how motivated a patient is to kind of help themselves. A lot of physical therapy and all that other jazz. Usually these injuries are below T1, any variety of actual vertebral height of the injury. Most of the time, the upper extremities are completely spared. Most of the time, they have no real difficulties with breathing or minimal difficulty with breathing. Usually a little more on the independent side. Other issues that you may encounter, and these are not necessarily, as I said, things that you're going to be diagnosing. These are things that you may have to may experience during like a transport or a home care kind of situation. Whereas central cord syndrome is usually due to a hyperextension of the cervical column. Usually this creates an issue more with the upper extremities than the lower extremities. So they'll have better control of bowels and the genital region, but they will have arm issues. We have anterior cord syndrome, right? So just the front part of the cord is affected. They will still have, this is due to flexion injuries. These patients usually have light touch that they can still sense, but like heavy touch, so if you gently touch them, they'll be able to feel that. They'll be able to know what their proprioception, where their limbs are in space, but they won't necessarily be able to feel pain or temperature. Then you have Brown-Séquard syndrome, which is a functional hemitransection, so only one side of the body is affected. So this is usually due to a ruptured disc or a bone intruding into the spinal cord, which causes a unilateral paralysis, very similar to what you would expect to see in a stroke, except whereas a stroke, the opposite side of the brain is affected from the side that shows weakness. This is the same side. So you'll have weakness and paralysis on one side and then loss of pain and temperature on the opposite side of the injury. Here's a fun picture of a variety of different neurological issues that the spinal damage to the spinal cord can create. So we're going to trust the Canadians here. when you are assessing a spinal cord or potential spinal cord injury, there's a number of things that you really need to take into account. First of all is the mechanism of injury, right? Low speed, low impact, low risk factor, right? You have a healthy adult patient who's wearing their seatbelt and remembers the entire situation. This would be considered, a low mechanism of injury. Is your patient altered mental? Is there actual spinal pain or tenderness? Are there any neurological deficits noted? Okay, if you actually feel a deformity, that is a huge problem, right? That would be a concern. And then you also have the potential for having an unreliable patient, right? So if drugs are involved, or if there is a pre-existing medical condition that maybe creates a cognitive delay or impairment, right? Like dementia, etc. These are going to still be high-risk patients. Yeah, I think that's about it. So when you're evaluating a spinal cord injury, these are a variety of things that you can do in order to assess. The most simple is obviously to have them move their arms and legs. They should have equal strength and motion in all of their extremities. Obviously, if they have a pre-existing concern, like a previous stroke that left them with a deficit, they need to be moving to their baseline. Okay. There should be no neck or back pain with or without palpation, right? And yes, you're definitely going to have those patients who are experiencing whiplash pain, but you should still have a certain level of suspicion with those patients, because that distracting injury could hide an underlying concern, and that could be just that they're self-splinting. Sensory findings, right? So you want to make sure that you do your pulse motor sensory and see if they have a ability to feel you. If they can't feel light touch, that's not a great sign. Unconscious patients, right? You're going to create a more toxic or noxious sensory experience for them to kind of see if they wake up or if they do not. And this is also useful for your Glasgow Coma Scale, right, when you're assessing a mental status. If you are able to, if a patient says, oh, I can feel, then all of a sudden they stop feeling, it's a good idea to mark where that location is so that when they get to the hospital, they can kind of determine where the injury might be. One of those really delightful state questions that they like to ask is, what is a normal Babinski? So a Babinski sign is a really great neurological assessment. You do a quick swoosh of the patient's foot. The patient should kind of push their toes down and kind of pull away. A patient who has an abnormal Babinski sign, their toes will go up, okay, and start to spread out. Not a good sign. This is only applicable to patients who are older than 2 years old, though, okay? Because under the age of 2, an abnormal Babinski sign is considered normal. Not to be confusing. Other responses that you will see that are usually indicative of a spinal cord injury: hypotension and bradycardia, temperature control issues, right? So if they have cool or hot extremities, depending on the length of time that they've experienced this injury. Priapism, always fun. Remember, check the 1%. So, general management. The first primary goal of spinal cord injury management is to prevent further injury, right? This is why we approach the patient head on. This is why when we take their C-spine precautions, we hold their head in a neutral position, okay? Your entire spine, while it's made up of 33 separate bones, should be treated as one long bone, because if you think about it, it does. It works in conjunction with one another to provide you literal structure, okay? your spinal motion should be the initial assessment, right? The initial inline position, like BSI, scene safety, C-spine precautions, right? We're all familiar with that. But do remember, because this is one of those test questions that they usually like to ask, what is the primary goal of spinal cord management? Is to prevent further injury. Don't be that guy. I've seen this. Mostly Fidney crews. It's wild. All right, so a number of different spinal motion restriction techniques are now around, right? Because now we have the ability to remove patients from a scene under more or less their own power. This is usually involves when you're sitting or standing by the patient's side, and you can move them over or help them stand after a cervical collar has been applied. A supine patient, usually we do a good solid log roll, right? Now that we aren't necessarily using long boards, we do have other options in terms of moving the patient off of the ground. You could potentially use a scoop stretcher, which is also a solid, similarly solid structure that we can get them up and onto the stretcher mattress with minimal motion. We do not use rapid extrication anymore. The standing takedown we don't do anymore. Rapid extrication we still potentially do. If your patient is prone, obviously you should be rolling them over, but you should put the longboard or your other moving device underneath them as you roll them over, so that you don't have to move them more than is absolutely necessary. Other special concerns, right? Pediatric patients, if they're wearing a helmet like football or motorcycles, and diving accidents. Diving accidents, the body hug. That only really works if you're tall, or standing in an adequate amount of water where you can actually maybe float the bottom half of their body. I can't imagine me doing that for somebody who's like 6'2". Be like, you're just gonna stay there. I'm gonna roll you over, but you're gonna kind of stay there, just float. This is good for patients who are in a prone position or in pools. Just it helps you keep their airway up and out of the water, right? Helmets. Okay. Now, first of all, the guy the helmet they removed totally looks like Freddie Mercury. So if you were rescuing Freddie Mercury, you're having a better day than most. But remember that if you have a patient who has a motorcycle helmet or a football helmet on, most of the time they will not be in that neutral position that we'd like, right? Unless, of course, that patient is also wearing shoulder pads, okay? So if you have a patient who's wearing football shoulder pads and you have access to their airway, you might actually consider leaving the helmet on because it's keeping their spine in a more neutral position than if you have just the helmet or just the shoulder pads, okay? So as long as you have a full access to their airway, that's a better situation. Two different types of shock that you may actually encounter in a patient who has serious spinal injuries. You have spinal shock and neurogenic shock. Spinal shock is usually temporary. Usually all of the autonomic dysfunction will resolve within 24 hours. And it's not necessarily a permanent injury, right? This is when the spine starts to swell up and the compression of being a too large spinal cord and a too small spinal canal creates a loss or depression of the spinal reflex action, right? So these are the patients who may actually recover all of their motor or sensory functions below the injury once the swelling goes down. Neurogenic shock, however, is a little more on the permanent side. This is usually the body having a sudden jolt to the system where it's lost the ability to control the body below the injury site. Usually this happens in patients who have been injured above the T6 location. All that sympathetic tone below the injury site, and now consider, right, that's very high up. That's just below the nipples. T4 is the nipple, so that's just below the nipples. That's a significant amount of body mass that no longer has sympathetic tone. Okay, so the body can no longer constrict blood vessels. It's just vasodilation. You have not enough blood in a large container, so the patient's going to be hypotensive. They're going to be bradycardic because the loss of sympathetic tone starts to stimulate the parasympathetic reaction. And the site below the injury will be warm, dry, and pink. And here's autonomic dysreflexia again, right? These are patients who have a spinal cord injury, usually above T6, who have some sort of irritating, noxious stimulus below their level of injury. Okay, so this causes a massive a massive sympathetic stimulation that can't be corrected below the injury site. So they have elevated blood pressure and a number of other concerns, right? So they'll be sweating above the site with a decreased heart rate, but everything below the injury site will be kind of cool because, again, remember, the body doesn't have the ability to control everything under there.
Cool.
Yep, go ahead.
What's the difference with that with autonomic dysreflexia?
So it's the length of time from the injury. So autonomic dysreflexia is usually like the patient's now at home. They have maybe a few years or something after they've actually incurred the injury, and now they have a full bladder that needs to be drained, and that's creating that response, as opposed to the other way that you're talking about, the autonomic response, which is like immediately or after the injury.
So Nicole, aside from that, is that some sort of interesting like primal response? I mean, you've obviously cut off the innervation to the area and something needs to be done and the body's alerting you to that. I mean, aside from just the name and the observation of what it is, I mean, beyond that, it seems like it's like a secondary mechanism, like the fight or flight type of, I mean, it's related to that in some ways, is it not?
To a certain extent, yeah. So there's something that's bothering you, right? So it could be a blister, or it could be irritation, right? And your body's going, oh my God, fix this. Like, I know it's there, but I know you can't feel it, but you need to fix it. And you're like, what you talking about, body? And the body's like, ah, and it just kind of cascades with the full response that you would expect, but it's only half the body because you only have control over half of the body.
So a paraplegic is gonna experience what you're talking about.
Potentially.
What I was talking about, anybody could experience that.
Yes, I think so.
That has that trauma.
Yes.
Okay.
Well, a quadriplegic too. It's anything over an injury at T6 or above.
Okay.
So in the field, then, if we come across a patient like this, obviously we're going to be trying to inquire maybe from a home health care aide or from the patient themselves about something that might be happening or looking for something that might be happening.
Yes. Yeah. So it would be like perhaps loosening a tight belt, taking shoes off, taking tight socks off. When was the patient last cathed? Because a lot of times patients who have a certain level of bladder control, instead of them having a Foley catheter, they'll straight cath themselves to relieve their bladder. So perhaps you have a paraplegic who is also a diabetic and their sugar's a little low, and they got a little forgetful and they didn't straight cath themselves. Or their home health aide was late today and they didn't straight cath them when they got there. So those things can create that noxious stimulus that creates this autonomic dysreflexia.
Is that a fairly common thing for somebody in this position? It would seem to be.
I want to say earlier in their new life as a paraplegic or quadriplegic, because they need to adjust to this new routine, right? So you don't really think about it, right? You have to go to the bathroom, you get up and you go to the bathroom. If you don't really feel that like stimulus to, hey, you have to pee, you could sit there and just chill, right? And you're just oh, I'm good, right? And then all of a sudden it's 2 hours, 3 hours later, and you're like, oh, that's not good. Something's annoying my body. So like a lot of these patients will like get into this groove, like every 2 hours they straight cath themselves to keep their bladder at a comfortable level. You know, they wear baggy clothes, they wear stuff that they know isn't going to bother them. So as they start to kind of figure out what those triggers are, is really kind of as they start to progress in their new lives as people who need to kind of take those things into consideration. Because you don't think about it until you have to.
Thank you very much.
You're welcome. Any other thoughts, questions? Yeah, no. Snowboarding, scary. Skiing, scary. A lot of sports are scary. Skydiving, also not recommended. All right, cool. Let's go on to the next one. Head, face, and neck. As I said, this is one of my favorite ones because of the French. But when we get there, we'll get there. This is your face. Your face is a relatively hollow kind of space, right? So 8 to 12 pounds, depending on how congested your sinuses are. You know, like those are the bad days. While your head is pretty much full of air, in which keeps it light, you also have relatively thin bones on the inside of your skull and relatively thick bones on the outside of your skull, right? And if someone has ever called you thick-headed, you should be like, yes, I am, thank you. But there's a lot of problems. And I do believe that this is something we talked about in the review. Your face receives blood from your internal and external carotid arteries. Everything above the neck, face, scalp, etc. bleeds. It bleeds a lot, okay? So don't be alarmed if there's a lot of blood. Most of the time it kind of self-limits itself after a while, as most bleeding does. The bigger concern that you should have when it comes to facial and head injuries is the airway and breathing management, right? If you have something like this gentleman right here, how are you going to control his airway?
What actually happened to this guy? Please tell me.
I do believe it's a gunshot wound.
Okay. Well, ABCs, right? I mean.
Yeah, but how would you manage this airway though?
Well,
Do you have
clear?
do you have clear anatomical locations?
Go for the throat.
I mean, I can't tell from the picture, but I mean, it's going to be real difficult to BVM the guy. There's going to be no secure seal. If you have some sort of opening there and it's not occluded somehow, and you can get an ET tube in there, obviously, but beyond that, it's a mystery to me. I mean, that nose looks like it's not going to take a nasogastric tube, that's for sure.
No. Would you put an NPA in this patient?
No.
Why?
An NPA, maybe.
NPA.
Maybe.
No, you wouldn't.
No, head
No,
trauma.
isn't it contraindicated for facial trauma?
Thank you.
Yeah.
Thank you. You don't want to go ventilating a brain.
RSI?
RSI. Potentially, yeah. If he's sitting up and he's like managing his airway, would you leave him?
If he's able to manage it on himself, but given condition to everything else, if it's unstable, yeah, go that route.
Okay, but like, would you potentially feel confident going, oh yeah, no, I'm going to get the airway?
I mean, his airway looks. It's there.
It's there. It's gaping. That's all
Probably
it's
breathing.
gaping.
Yeah.
Yeah, he's sitting up.
I was gonna say, sitting up, he's looking at us in the picture.
Yeah.
So presumably, maybe we do nothing.
It's exactly. Sometimes the best treatment is actually doing nothing, because this patient, you might go into, you might RSI him, you put him down. How are you going to ventilate him if you can't get the tube? Right? Perhaps, you go in there and you see absolutely nothing. You're not sure about what your anatomical locations are. What are you going to do? You can't get a good seal for BVM. How are you going to ventilate him when now you've taken over his airway? And his breathing. So, good considerations that we definitely want to take. You probably will lose an OPA in there also.
All right. So you asked us what we would do. What would you do?
It would depend. It would depend on how awake, if anything. So if he's sitting up and chilling like that, I'd probably leave it and go to the hospital. You know, put a cervical collar on him, bandage that as best as possible, and a non-rebreather.
You'd really try to cervical collar that, really?
Yeah, because I don't know where the extent of the injury. Because now imagine, when we talked about this, when we were talking about like gunshot wounds and stuff, if he used a shotgun with a slug, that pressure wave could have gone all the way back to his spine. Just judging by the amount of the extent of the damage in the front. You can also see, if you look at his face, obviously his nose is starting to swell up, right? Because that was from the pressure blast from the gunshot wound. You can see around his eyes, right underneath his eyes, he's starting to get raccoon eyes. Raccoon eyes are usually a sign of what? Intracranial basilar skull fractures. So if you've got a skull fracture, there's a good possibility that he also has a spinal injury. So yeah, I would attempt to cervical spine that. If I can't get it all the way around, maybe use like a towel or a blanket or something to stabilize that head as best as possible.
If you have uncontrolled bleeding with this and you don't want to occlude the airway, because you kind of can't really even see where the airway is,
yeah,
would you just, kind of...
Yeah, I think you just sir, hold that right there. I think you would probably do a little bit of a creative action. So he has that avulsed, what looks like his jaw is avulsed down. So maybe take a 5x8 and wrap it up, and then do like a full Ebenezer Scrooge like facial wrap.
Yeah.
Might help control that bleeding a little bit.
Okay.
But yeah, no, that's a great question, and this is why you have to sometimes be very creative in EMS. You're like, what's going on? Not sure. Just
okay. So not to make too fine a point on it. So now we're treating him, and we decide, okay, he's got some bleeding going on, but to wrap him up like that might actually just close off his airway. I mean, that very simple technique.
Yep, it could.
Yeah.
And that's why you'd have to be very, very careful and reassess and reassess and reassess.
And obviously, there's no communication going on with this guy.
Probably very limited, and it's probably a little bit of like, ow, ow, ow. Would you use pain management for this patient?
Fuck yeah.
What would you use?
Fentanyl.
How much? What's your dosing for fentanyl?
Isn't it like 0.2 milligrams per something?
Max 200 is getting the whole thing.
It's
Don't you have a head
one mic
there,
per
or-
kig. 1 mic per kig. You're like really not helping his pain, Rob. You're just like, you're good. I'm gonna give you something for the pain. Not really. Evil. What's that, Joe?
What about the head injury, though?
Would you call?
Yes, you'd have to call, I think.
Good. Yes, I would recommend. And well, this also depends on where you are, because if you're in Nassau or Suffolk, they'd be like, just sprinkle him with fentanyl and go to the hospital. In the city, they're like, Mother, may I? He blew off the bottom half of his face. Can I give him fentanyl? They'd be like, half dose, probably. So, again, know your system. Know your where you are. All right. A lot of different there are a number of different facial structures and bones that make up the face. Excuse me. So obviously you have the easiest bone to kind of identify, which is your mandible, right? The jawbone. The jawbone's connected to the midface, or the maxilla, right? Which is that bone right underneath your nose where your teeth kind of come in, right? So that's that maxilla. You have your zygoma, which is right around, right this like cheekbone. And then you have your orbit, which is the rest of the eye socket. And then you have your nose, right? So you have that little nasal bone. The majority of your nose is actually consistent of cartilage. Somebody opened the door. It's very squeaky.
Nicole, I'm sorry. One more question about the other guy.
Sure, no problem.
Transport sitting up.
Yes.
That's still my last question. I mean, he's sitting up, obviously. It came to my mind. I'm sorry. I don't mean to belabor that point. But
It's okay. Yeah, unless of course you have to start doing some sort of emergency procedures, then you would have to potentially lay him down. Would you consider intubating him while he's sitting up?
I've heard of that happening. I've heard stories about it. I mean, it's not the best position, but I've heard people doing it in MVAs and so forth.
Mm-hmm. Now, if you're sitting up and you're facing him and you can see right down his airway, would you want to lay him down to intubate?
No.
Right? You got a clear shot, just
Right.
throw it in. Because once you lay him down, you might lose your anatomical markers. Once you lay him down, it might collapse onto his airway, making it actually like impossible to actually get an airway. Good question, though. Very good. So mandible fractures, right? For the most part, mandible fractures are relatively common, right? Your kind of jaw sticks out there, you get punched, that's what's getting hit. For the most part, right? You take one to the chin. Because it's a curious shape, it can break in a number of different locations. The number one symptom of a broken mandible is probably like a dental, like misalignment, right? People will be like, it doesn't feel like my teeth are lined up well. You can also have numbness in the chin because that mandible can actually sever the nerves that innervate the location. And sometimes patients will actually have the inability to open their mouth secondary to it, especially if it's high up, because now they've lost that hinge, right? So if you like up here, right, this is what articulates with the TMJ, right? They're the temporomandibular joint right there, right? So if it's broken up here or even down here, they're going to have a hard time opening their jaw because the muscles that open it aren't going to be actually able to pull against the bone. And the muscles are spasming and they're going to spasm it closed, right? That self-splinting that we talked about before. Sometimes patients can actually dislocate their own jaw through a really big yawn. And if they happen to do that, they might actually be like, my mouth is stuck open. Fun facts. Blunt trauma is usually the cause of mandible fractures. So, the midface. Okay, so your midface is consistent of two different regions, right? You have the central one, which is primarily made of the maxilla, and then you have the lateral midface, which is made of the zygoma. Okay, the nose and the orbits are included in this area, but those are the two primary like bony structures in this region. Once upon a time, in the early 17 and 1800s, or late 17, early 1800s, the French were really into body snatching. There was a difficult time for physicians as a whole to get bodies in order to do experiments on, as well as like they were really into anatomy, right? This is the time in his human history where we're like, the body, it does things, let's name them all. Okay, so they would do anatomical dissections of corpses in order to kind of like locate different things in the body, perfect surgical procedures, etc., etc. So this one French dude named, shockingly, Lefort took cannonballs and smashed them into the faces of corpses to determine how the face would break. The French, man, they're wild. So it was broken into three typical fracture patterns. The first being Lefort 1, which is a separation of the central midface and the lateral midface right along the maxilla and the nose. Type 2 was higher up, where it went across the nasal bones and down across the orbits of the eyes. And then you had Lefort 3, which was highly complex, okay, and the facial bones would actually completely separate from the cranial vault, okay. Remember, corpses suffered for this scientific knowledge. So, Lefort fractures typically present with what's called horse face, right? So it's like a lengthening of the face, because now think about it, you have this kind of gap in that middle face region where it's just pulling the whole face down because it's separated. That mid face, that maxilla, is going to be unstable. The patient might have a nosebleed. They might not be able to feel like their upper teeth. Their nose might look very flat. Think smacked in the face with a cannonball. There could be CSF leakage from the nose, okay? Any basilar fracture may include CSF leakage from the nose, okay? And it's just a very puffy, like swollen, lengthened looking face, which is, the traditional sign of being hit with a cannonball. Sometimes you have cheekbone fractures. Cheekbones are not particularly easily fractured because it's a very quote-unquote sturdy construction. We designed those really well. The front of the face, not as much. If the patient does actually have a zygoma fracture, it usually looks like their face is kind of flat. Again, epistaxis, any sort of facial injury can really disrupt the nose and all the arteries and stuff that run through the nose. Some numbness is also very common because, again, remember, you have those cranial nerves running straight through the face, which can be damaged very easily. The problem with zygoma fractures, if they do actually occur, is that the very thin orbital bones inside the eye itself tend to be damaged as well. And when those get damaged, they can cause a lot of injury to the eye, the actual eyeball, or the nerve and or the muscles around the eye. So patients will have altered vision and other concerns that are probably the bigger problem. So the orbit kind of looks like is actually shaped more like a pyramid rather than like a circle, and it shelters your eyeball. We talked about this already, though. The bones are super thin. If there's some sort of direct trauma to the eye or the orbit itself, it's going to potentially fracture those bones. Most of the time, this is like sporting injuries, people who are hit directly in the eye with like a baseball going at a relatively fast rate of speed. The bigger issue is what's called a blowout fracture. Okay, so this is when like a baseball or a basketball or something that's a little bit larger than the orbit hits the eye and the surrounding tissue, and then that increased pressure, right? Remember, because it's always about pressure, that transmission of energy, that pressure to the eye actually will cause the bottom of the orbit, sometimes it's on top, sometimes it's underneath, to actually go poof, and just literally blow out. The problem with that is that it creates a sharp and pointy, bone fragment inside the orbit. So it can cause a lot of damage to the eye, the muscles, etc. Blowout fractures tend to have a kind of, obviously, like one black eye kind of vibe, but there's a lot of swelling. And as the intraocular pressure starts to increase, it could actually start to push the eye forward a little bit. What else? Sometimes you could have some of the issues trapped in the fluid and soft tissue actually end up trapped in the sinuses. Because you weren't having a bad enough day as it is, you also needed to have extra sinus pressure. Nose fractures, super common, right? Your whole nose just goes poof, okay, right? Because once you get past like right about that mid part of your nose, it's all cartilage. Cartilage does not have its own blood supply, so it does not heal as rapidly as bone or muscle or tissue. And if you think about it, your nose is sort of just sticking out there in the front of your face unprotected. So it is a very poorly structured and highly vulnerable bodily feature that we have. Sometimes your patient might not actually have like a really dramatic looking nasal fracture where it's all off to the side. But they may actually have just some swelling and some nosebleed going on. As with any other injury to the head, you want to consider C-spine, obviously. You want to make sure that the airway is clear, because sometimes those bones and those bone fragments can end up inside the airway. Blood is always frequently an issue. And again, epistaxis, especially in unconscious patients. I can't tell you the number of times I've had patients who've had facial injuries, who were knocked unconscious or were drunk, and they were down and their airway was just full of blood and they aspirated blood. It happens, okay? So make sure that you take that into consideration when you are doing your patient assessment. Questions, thoughts, concerns? If you would like to know more about Lefort fractures, because if you're that kind of nerd like I am, there's a book called Stiff by Mary Roach, and she goes into the whole body snatching cannonballs into the face thing. It's kind of cool.
Well, in fact, just
Go ahead.
Nicole, wasn't that where a lot of, I mean, you mentioned that time period, and Andrew and I are both students of history. So wasn't that the time period that they were, aside from the face, they were doing a lot with the human body?
Oh, yeah.
A lot of the more modern medical knowledge comes from.
Yes, that's pretty where the majority of our modern medical knowledge comes from. Though I will give credit to the Greeks, the Romans, and the Egyptians. They also did a lot of pretty wild things back in the day. But I guess like the documentation was not as scientific because they figured it out and they were like, and this is what you do for this, and like they didn't have like the whole 7-step scientific process that they kind of originated back in those times of body snatching and medicine and quote unquote medicine.
So did they take the anatomical position that we use today? Is that because Leonardo da Vinci used to make drawings and he used to do a lot with the anatomical position? Is that where it comes from, or did he actually borrow that from?
So Da Vinci was actually an anatomist also. He wasn't necessarily doing all of like the slicing and dicing, but a lot of those artists of that period were actually hired by physicians, etc., to carefully document like what the body looked like. So a lot of Da Vinci's work is actually, he does have a lot of medical drawings, which is kind of freaking cool. So yes and no. So he was really into the human body and like how it worked and like the whole mechanism and physiology of it, but he worked usually in conjunction with an anatomist who was doing all the slicing and dicing.
Okay, thank you very much.
You're welcome. Ears, again, kind of vulnerable little flaps of skin on the outside of the ear, of the head. Usually the most common lacerations and contusions are damage to the auricle, which is that fleshy bit on the outside. Very commonly in like little kids versus dog, right? They have that dogs are like, your ear looks delicious. In the event that there is a chemical injury to the ear, you're going to irrigate just like you would an eye, but you're going to have the fluid sit in the ear for a few minutes before you drain and repeat. More commonly, especially in the event of pressure waves, etc., or really just people with overaggressive Q-tipping, traumatic perforations of the eardrum specifically. Okay, so usually the tympanic membrane covers the entire ear, like the mid-ear. If someone is a little, as I said, aggressive with a Q-tip, or there's an explosion or really loud music, it can actually perforate or rupture the eardrum. This can also happen from barotrauma from like high altitudes and scuba diving, or if you have a patient who has a really bad ear infection, okay? If the ear infection gets bad enough, it can actually burst the eardrum from the inside out. Most of the time, eye trauma is caused by a number of items flying at an eyeball, falls, fire and burns, motor vehicle crashes, various environmental causes. Everyone's gotten something in their eye at some point or another. If it's really, really bad, you could potentially notice in the actual eye injury, the eye can actually become avulsed, where it becomes ejected from the orbit, right? Blurred vision is a concern. Anything that there's if there's a change in the visual acuity field, that should be taken in seriously. Okay, it could be that it's a detached retina, it could be a scratch, it could be a number of different things. But if it's not dealt with appropriately, it could lead to long-term permanent damage. If anyone was concerned or worried, this is called a Snellen chart. That is the first and last time you're ever going to hear that term. It is recommended that you do understand how to assess a patient's visual acuity. I don't know anyone who's ever had to check a patient's visual acuity on the ambulance. I guess this would be more if you were doing community paramedicine or working in a doctor's office. The bigger takeaway that you should, the larger takeaway that you should take from this is just because a patient has two eyeballs does not mean that they're both natural. If they have an ocular prosthetic, don't go writing that the pupils were equal round reactive to light. So, actually assess both eyeballs because people have actually gotten jammed up on that. Other things such as cataracts or glaucoma can also impact the way the eyes look. I've had patients who've actually had square pupils because they had eye surgery and their iris had which is the ring of muscle that controls the pupil, had been nicked during the surgery. Seen it a lot. Happens a lot in cataract surgery, and corrective surgery as well.
Nicole, blind people, their pupils don't constrict, right, or dilate.
It depends on the type of blindness, because there's a number of different types of blindness. Excuse me. So, if, for example, it was due to a nerve, like the optic nerve was damaged, their pupils may still react perfectly normal. If it was secondary to an injury or a poorly formed eye, then yes, you might not actually have any pupillary reaction.
Cool.
So pupils, right, traditionally are black, round, and equal. They should react the same. There are some patients who have a very normal difference in the size of their pupils. One pupil might be a little bit larger than the other. Not uncommon. Any sort of direct trauma to the pupillary sphincter, as I said, like that what the iris is made of, that muscle that controls the pupil, can cause abnormalities. Your cranial nerves create the motion for your eyeballs. The iris and the ciliary muscles are the only ones that are involuntary and sympathetic. The rest of your cranial nerves are under your control and help you move your eyeballs around. So this is cranial nerves 3, 4, and 6. 5 is off doing something else.
Nicole, if we come across an eyeball that is no longer in the socket, what do we do with that?
You put it in a cup.
No, I mean, let's say it's still attached.
Yes, it should. Hopefully, it should still be attached. There's 3 muscles and the optic nerve that should keep it attached. It might be bulging. It might be actually dangling. But you should literally put it in a cup. You're supposed to take a non-styrofoam cup, put it around. You can dress the eye in like moist dressing, and then put the cup over the eye socket and tape it in place, and then cover the patient's other eye to prevent sympathetic motion.
Thank you.
You're welcome.
Just, put some saline on it and pop it back in.
Do not pop it back in. So basically, you can actually impinge the optic nerve and/or the muscles around the eye if you pop it back in. But there are definitely people who do that, like weird human tricks kind of vibe, where they pop their eyeballs out, pop them back in. Ugh.
And would you want it to be loose inside that cup, or would you want to just put some moist dressing in the cup and then put it in?
I think you should pad it appropriately. Yeah, I think that's a good plan. You don't want it bouncing around, especially depending if where you're driving. Imagine going down Jamaica Avenue and somebody's eyeballs bouncing around inside of a cup.
Now, where do you find cups in the middle of the street?
That's a great question.
The same way the firefighter found ice in the bar.
It's true. You pop into the nearest bar. Hi, do you have a plastic cup? What? I mean, if you don't have a cup, obviously you can put a big bulky moist dressing around the eye and kind of protect it. The idea of the cup is to prevent you from accidentally poking it or hitting it. So if you do not actually have a cup available, you could do that. Or alternatively, you can also get creative. If you have the saline, right, the saline bottle, if you cut the top off, because can't tell me that y'all don't have knives.
I was just thinking about that.
Yeah, you could do that, like nice moist dressing, and then just put the bottom of the saline cup over the face, like loosely. Just basically the biggest concern there would be making sure that you don't actually like cut the patient's skin with like the sharp plastic.
Thank you, Nicole.
You're welcome. Other issues that you can experience for eye trauma is foreign bodies, obviously. As seen here in this picture, right? You put a bulky dressing around it, make sure you don't bump into it, and bandage it and stabilize it appropriately. Corneal abrasions, right? When you get something in your eye and just scratch it up, which you may need to do sympathetic bandaging to keep the patient from moving their eye around. Traumatic hyphema, which is what we just talked about, popping the eyeballs out. Vitreous hemorrhage, right? So if there's some sort of actual puncture wound to the eyeball, it can hemorrhage the vitreous fluid inside. Again, bulky bandages, sympathetic bandaging, and dislocation of the lens. Yet again, same treatment. You're not going to really alter your treatment there. Dental trauma. So this was the BLS update that we can now reimplant teeth. Best reimplantation was within 1 hour. You should put it in milk if possible, if you do not have the commercial tooth saver magic thing on your ambulance, which I don't think anyone really does. Again, if you're going to go get some milk, you're probably going to be walking into a patient's house or a bar. Hi, can I get a cup of milk, please? Most adults have 32 teeth. Your dental health is directly related to your cardiac health as well. Everyone, I'm sure, has had patients who've had some gnarly looking teeth. It happens. A lot of injuries that can affect the face can also impact the teeth. But loose and or dislocated teeth can also become a risk for aspiration. All right, the 3 zones of the neck. Okay, zone 1, from the clavicles to just underneath the thyroid cartilage, the cricoid thyroid cartilage right there. Okay, that's your first zone. The second zone is from there to the bottom of the chin, the angle of the mandible, and then the angle of the mandible up to the base of the occiput. So up low. Okay, those are your 3 zones of the neck. Obviously, there's a lot of very important vasculature that runs through these zones. You also have the airway and the esophagus, all super essential. Zone 3 issues is you could also have not only cervical spine concerns, but brain problems, right? Depending on how if there was an injury, how that affected there. Anyone remember this? This was like a bunch of years ago. He got his neck sliced by competitors. He's the goalie. Got his neck sliced accidentally by a competitor's skate, and the athletic trainer actually saved his life by running out into the ice and pinching his carotid closed. Hockey. Way cooler than football.
His name is Clint Malarchuk, if you want to look it up.
Thank you. I wasn't going to pronounce that much Malarchuk today.
All right, so just very quickly on that, interesting approach. It's obviously on one side, so we pinch off one side, we still have blood flow to the other.
Correct.
Okay.
Yes. Perfect. And also, don't forget, you have your you have the carotid, and you have other arteries running up the back of the neck that can convene, that's the right word, in the circle of Willis at the base of the brain. So the brain, if you only damage one artery, you still have the circle of Willis protecting your brain health. Other issues, anterior neck trauma concerns, right? We talked about strangulation, we talked about hangings, firearms and stabbings, pretty traditional injuries that are seen. Contact sports always have their risks. Obviously, motor vehicle accidents and or any blow to the neck, right? Because if you have somebody who either takes a steering wheel or a fist right to the larynx, they can actually collapse the trachea and create all sorts of concerns there. Horses, I do not trust horses. Like I know there's like a whole group of people who are like, oh my god, I love horses. Don't trust horses. I worked in Melville, and they have the trails and stuff. Horses get mean. If they decide they don't like you, they're like, yeah, guess what? And just throw you. Because there's nothing quite as fun as getting chucked by a 2-ton, like a 1-ton animal, who then decides he's going to trot on you. Like, ha, 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 ha. They get mean. But yeah, so if you're getting chucked, you're getting thrown, any sort of neck injury is a possibility. And it's going to create a difficult airway and all sorts of other complications in that realm. So another concern with that anterior neck injury, neck trauma, is even soft tissue injury can be of a concern, because if there's a significant amount of hematoma or swelling, it can actually compress the trachea itself. So now, even though the patient's trachea might not be actually directly injured, it can still be compressed by the swelling. Other concerns or any sort of penetrating trauma. How would you bandage penetrating trauma to the neck?
Well, I think we saw a little bit earlier circular bandages, something to protect it and secure it in place.
Don't
Like
you
a-
use like an occlusive dressing?
Yes, perfect. Occlusive dressing. Yes, you might have to, depending
Non-porous,
on where the injury is, you might. I wouldn't necessarily recommend a circumferential, just because it could restrict airflow. But definitely, if you have any sort of injury from zone 3 or up, an occlusive dressing is essential to prevent potential air embolisms. Okay. Perfect. Look at that subcutaneous emphysema right there. See it? In that guy's neck? It's living there like a big old blob. Injuries to the anterior neck in particular. Not only the esophagus, so the esophagus is relatively well protected, but it can create issues. Bigger issue is going to be that there's stomach acid, etc., going to that region. But tracheal damage as well can create subcutaneous emphysema. Any damage to the bronchiotracheal tree can create subcutaneous emphysema. Has anyone had anybody who's had subcu emphysema? No? It's pretty wild. So one of the recommendations I make is you go get a Rice Krispie treat and kind of molest it a little bit. That's what subcu emphysema feels like. Okay? Like, just think about that vibe, like that like snap, crackle, pop kind of feel. That is subcu emphysema. Had a patient once, guy fell down, took a header, straight down a flight of stairs. AMS tubed him. First ventilation, everything from his nipples up went whoop, and it was like, oh no. Full of subcutaneous emphysema. I was like, I don't, okay, so clearly he has some sort of damage along the tracheobronchial tree. This was also right around the same time that Flushing managed to put an endotracheal tube right through somebody's carina, so I went to my partner, Mike, extubate him. We can't be know for sure where we are. He's like, I have lung sounds. Like, just freaking extubate him. So we went to the hospital, and they were like, oh no, he has some sort of damage. So keep that in mind. You can actually have, the first ventilation, you can have sub-Q emphysema. It usually just means that there's some level of damage to the tracheobronchial tree. Too much that can build up externally, okay, and create difficulty with chest compliance. So just keep that in mind. Oop, too far. Oh, head trauma. We talked about this already. Heads bleed a lot. Oh, I'm trying to blow a piece of hair off the screen. That happens to be a piece of the picture. Most of the time, they can be relatively innocuous, right? They're just a soft tissue injury. But sometimes you can have a damage to the skull underneath, right? There's probably about 1.5 inches worth of tissue between your scalp and your skull. Like, you wouldn't think it. And I know you guys don't get to go to the morgue, but there is a significant amount of tissue and muscle that goes between your scalp and your skull. Two different issues that you really might be dealing with is a stellate wound, which is commonly associated with a gunshot wound. It gives you this stellate or star pattern, right? Because that's that high pressure, high velocity injury. And then you have subgaleal hematomas. Subgaleal hematomas is a collection of blood in between the scalp and the skull. Pretty gruesome looking. Little more gruesome looking in young children who also have those non-closed fontanelles, but it's like the whole head will look just like big, puffy, and kind of squishy. Different skull fractures, okay? Basilar skull fractures can be anywhere along the base of the skull, which is like along the temporal bone or around the side, to inside the skull itself, which is like along the orbits or the nasal passages, right? That separation from where the brain sits to like the mouth area. Open vault is when you have a full open injury. Depressed skull fractures, it takes quite a lot of force to depress a skull fracture. The concern with that is that you have sharp fragments of bone pushing into the brain, not helpful. Linear fractures are relatively well maintained, right? You literally just kind of cracked your head. They don't do anything for it. And then you have comminuted, which is like a little more open. Skull fractures have a lot of different complications, okay? So as we talked about already, there's a lot of blood vessels in that region. There's a high possibility for infection, okay? Because now you have an open space between your cerebrospinal fluid and that cranial vault and the outside environment. Underlying brain injuries and cranial nerve injury. The one cranial nerve that they do not check during a trauma assessment in the ER is the cranial nerve 1, which is your sense of smell, which is commonly damaged with facial/basilar skull fractures. Most skull fractures are linear in nature, okay, just based on the fact that your skull is the way it's shaped. It kind of diffuses some of the force. So as long as you don't have like a actual direct concentrated force, you won't necessarily get that like depressed skull fracture. Most of the time, you don't necessarily have any external signs of a injury. The scalp laceration may not actually occur. If the linear fracture does cross one of the meningeal grooves, which is where those fontanelles fuse together, it could lead to epidural bleeding because that vasculature runs right across those grooves. I don't know if anyone actually recognizes that. That's my ear. That's my battle sign. Basilar skull fractures are usually associated with major impact, okay? The primary signs of a basilar skull fracture are your raccoon eyes, hemotympanium, which is the blood collection behind the eardrum, CSF leakage, traditionally from the nose, and battle signs. Battle signs take a little time to develop, but it's that bruise right behind the ear, and it can go all the way down your neck, as from experience. Could be depending on where the injury is, you can have a significant hemorrhage if the carotid arteries are involved. Look at this dude. Like, let's talk about the before and after. That's a depressed skull fracture of an MMA fighter. And then they replaced that bit of skull with a titanium plate. Little bit of a dent, smidgen of a dent. Most of the time, depressed skull fractures are caused by a small object striking the head or the skull at a high rate of speed, right? It's a very focused energy transmission. Most of the time, there is a level of a scalp laceration associated with it, except if you're this guy, apparently, who's just super smiley. The frontal bones and the parietal bones, which are the ones on the side, are usually the ones that are most commonly damaged in this fashion. Cerebral contusions, right? TBIs are very common in this situation. Open vault. when your brain says, "I'm out, guys, peace," there is an actual literal opening between the world and your brain. Usually it's very high force, compressive force, blunt trauma, but like usually it's significant, and most of the time it is deadly. Okay, these are not the most survivable of injuries. Your brain likes to be inside, safe and protected, and not hanging out with, you outside. Number of different injuries that can happen due to the cranial nerves. If they are in fact injured, so your olfactory nerve, right, gives you a sense of smell. Basal skull fractures can take those out pretty easily. Cranial nerve 2, relatively well protected in the back of the orbit, but if they are damaged, blindness or other visual field defects. Cranial nerve 3, which helps move your eyes. If it's damaged, you'll have a patient with a dilated fixed pupil. Sometimes, we see the dilated fixed pupil and also in patients with brain bleeds. So if this cranial nerve 3 is being compressed by a bleed, you will have a patient with a dilated and fixed pupil. Cranial nerve 4, 5, 6, 7. I gotta count there, my Roman numerals. Down your facial nerve, okay, so you'll have delayed facial paralysis. These are common in basal skull fractures. This is also what you see in patients who have Bell's palsy. Okay. Deafness for cranial nerve 8. Basal skull fractures, again, right? Think about where these nerves are coming out, and what part of the skull or fractured skull will affect them. Traumatic brain injuries affect a significant number of people. The NFL is actually doing a lot of research on it because of the whole idea of the fact that they're literally paying these men millions of dollars to go smash their heads into things. Fun fact, rugby players who have significantly less head protection actually have a much lower level of brain injury than football players do. Because football players have this idea that because they're wearing a helmet, they're super safe. A traumatic brain injury is, in fact, characterized by an alteration in brain function, usually due to an external force, right? So you got hit in the head, you were in a car accident, etc., you had a brain bleed or something to that effect. A traumatic brain injury is the new classification that you get to call yourself, the new club you join. Secondary traumatic brain injuries can be due to various intra or extracellular derangements as a consequence of the injury. Okay, so hypoxia, secondary. So like if you hit your head and were rendered unconscious and then became hypoxic, you could potentially have a primary and a secondary traumatic brain injury due to the hypoxia. The part of the brain that is affected also will give you kind of what your traditional signs and symptoms are. So a frontal lobe would be language, personality, right? You can be more irritable. Your temporal has your memory. So here is a section of the red. Your occipital region is really what primarily gives you your vision. Your parietal lobe is your reading and spatial misperceptions. Brainstem and your cerebellum, if these parts of your brain are injured, you're going to have a higher morbidity mortality rate because there are your reptilian reflexes, such as breathing, swallowing, heart rate, etc. Also gives you a sense of balance and clear speech. We don't call concussions anymore. They are now called diffuse axonal injuries. Moderate or severe diffuse axonal injuries can cause global issues, as can hypoxic and/or ischemic damage, meningitis, and other vascular injuries. Usually, focal injuries are, again, kind of related to that direct, focused pressure, or an internal brain hemorrhage where like an aneurysm bursts and a very specific part of the brain is affected by lack of blood flow. Concussions may or may not involve a loss of consciousness. They very frequently involve vomiting, restlessness, maybe some confusion, various coordination defects, equilibrium defects. A lot of the times they can also have memory concerns. So if you have a patient who can't remember anything that happened earlier that day, they have what's called retrograde amnesia. If you have a patient who's having a hard time making brand new memories, that's called anterograde amnesia. Generally, retrograde amnesia is very commonly associated with concussions. Anterograde amnesia can be a sign of a more serious concern. It's also good when you're doing an assessment of patients who do potentially have amnesia to find out what the last thing they remember is. Okay. Moderate diffusion axonal injuries, commonly commonly characterized by a period of unconsciousness with persistent confusion. Okay, so the patient is knocked unconscious, they wake up and they're still very, very confused. A lot of them have extensive amnesia. Severe diffuse axonal injury is massive damage to the brain, potentially extending into the brain stem. Very long period of unconsciousness. They also might experience abnormal posturing associated with increased intracranial pressure. Most of the time, focal injuries are pretty observable. Like you can kind of tell where the injury is. If there is an open vault injury where the brain is actually exposed, the patient might do better, barring infection, etc., because the swelling has somewhere and bleeding has a place to escape. Things that you need to make sure that you know the difference of is the difference between an epidural and a subdural hematoma. An epidural is a slow, hold on, making sure I get it right. It's a slow venous bleed. A subdural is a faster arterial bleed. Contusions, right? This is cerebral contusion. It could be again, secondary to trauma. A little bit of a larger area that's bruised. Remember, blood is very irritating to your body when it's not inside your vasculature. So this is what causes a lot of the issues when it comes to symptoms. Excuse me. All right. So your body does a really good job of making sure that your brain gets blood. Your brain uses about 20% of your body's oxygen and 25% of your body's glucose. So this is why hypoxic and/or hypoglycemic patients are so altered, because the brain is a very high functioning machine and it needs all of that energy and oxygen. Primarily your brain is kind of measured in how much pressure is going on, right? So your cerebral perfusion pressure is related to your mean arterial pressure and your intracranial pressure. So if you have a increase in your intracranial pressure, your body responds by increasing your blood pressure. Okay, this is how we get that Beck's triad, the signs and symptoms of the posturing. So as the intracranial pressure starts to increase, for perhaps due to an injury or a brain bleed, their body goes, oh, well, let's increase the arterial pressure because the brain needs more oxygen, it needs more glucose, let's get it what it needs. So as it increases the mean arterial pressure, the intracranial pressure also starts to rise. And as these two are rising, the cerebral perfusion pressure starts to get worse. Okay, and this is what causes the posturing that we see. And this is why you have patients who have a brain bleed and have a blood pressure of like 190/80, like a very high blood pressure. Sorry, it's Cushing's reflex. So we just talked about this, right? So as the pressure in the cranial vault starts to go up, the brain starts to go out down the magnum ovale.
What you mean magnum foramen?
Yep, that one. I always get my foramens and my ovales all confused. Posturing. Decorticate. The patient is holding their life into their core. Decerebrate, they have let go of life. Okay? Decorticate, well, not good, is slightly better than decerebrate. The state test loves to ask questions about what it looks like. So a decorticate posturing is an extension of the legs and a flexion of the arms, whereas decerebrate is a extension of all the arms, with usually the flexion is at the wrists and the ankles.
I saw this kid. He hung himself, but fire got there. Well, we all got there pretty fast. And fire found him hanging, I think, by a belt behind his door. And then they laid him down. And when I got there, he was posturing to corticate. So I saw him. He was breathing shallow and fast. So we bagged him, and then he started posturing the server.
Whew. Yeah, he probably has a serious diffuse brain injury from the pressure. So one of the secondary concerns when it comes to hangings is that depending on how you're being hung, if you only restrict the venous blood flow, you'll have a lot of blood getting into your head, but it can't escape, so it starts to back up and kind of create increased pressure. Or, if you have good venous outflow but no good arterial inflow, you have a more significant hypoxic injury. But yeah, if your brain is also seriously hypoxic, it does similar posturing problems.
So would the term then traumatic brain injury, would that incorporate any kind of injury to the brain like what you just described?
Yes.
Okay.
All right, I got these backwards. Epidural is an arterial. Subdural is venous. I don't know if I said that right the first time. So epidural hematomas are usually pretty easy to spot when you have a patient with an epidural because it's an artery, so it rapidly expands. Subdural hematomas, because it's a venous blood escaping, it's a lot slower. And usually you'll see the difference, especially in the imaging. The epidural starts to kind of look like a solid kind of orange or like a fruit shape, where the subdural will actually kind of look like a crescent moon because it will spread throughout from its point of origin around until it can no longer spread, and then it starts to push in. So a subdural is one of those patients who they bang their head real hard, they lose consciousness, they're perfectly A-OK, they go to bed that night and they never wake up because the subdural hematoma starts to grow and grow and grow. Whereas the epidural patients are the ones who hit their head and then have like instantaneous alterations of cognition. That's really your two defining. And then you also have a subarachnoid bleeds, which is when you have what they call a quote-unquote thunderclap headache, and it's just a serious, significant bleed where the subarachnoid space fills up with arterial blood right away. There you go.
So you got the. Oh.
What's that?
No, I was gonna say about the layers of the brain. So you got the subdural, then epidural, then subarachnoid.
Yes. So your epidural. So your arteries are outside of the brain. They run between the skull and the dura mater. Okay, so if you have an epidural arterial bleed, it's in this space. So the dura, because it's so thick, it kind of restricts the amount of blood that escapes, or the space in which it can escape, so it will push directly into the brain. Whereas the subdural, because it's between the dura and the brain is a lot more compressible, so this will spread a lot further around, like in this picture. So it's like this is a subdural hematoma, where before you actually start to see signs and symptoms is that you have a significantly larger amount of blood than if you have an epidural, because the epidural just is like a direct insult to the brain. It starts pushing it right away because that blood doesn't have a lot of place to go. Make sense? So the problem with subarachnoid hemorrhages is usually deep within the brain, so it's harder to treat, and it's usually a rupture of a berry aneurysm. Other significantly big issues are the intracerebral hemorrhages. This is when you have blood inside the brain matter itself or within the ventricles. Once blood gets in the ventricles, it's kind of an end game. Like, they really have a hard time fixing that problem. Let's see. Here's your subarachnoid. So your subarachnoid starts to fill the fissures in between the brain. Sudden and severe headache. These patients will be like, wow, especially patients who never have headaches before, all of a sudden start complaining of a headache. You should be suspicious of a subarachnoid. Commonly, it's due to an aneurysm or a rupture or an AV abnormality, which is when your artery and your vein connect directly and it starts to bulge out. Cerebral hematomas, again, this is like your brain bleeds, right? These are, or secondary to like a high velocity injury, like a gunshot wound. These will create like just blood and tissue and potentially bony fragments inside the significant part of your brain, which does all of the important thinking for you. One really kind of interesting thing that you see, we talked about a little bit in cardiology, is that if you have a patient who has a brain bleed, they can actually throw some really wild dysrhythmias and really deep inverted T waves. And if you correct the brain bleed, you'll correct, or the traumatic brain concern, you'll correct the cardiovascular abnormalities or arrhythmias. Depending on where the injury to the brain is, can also affect how well the heart works. So, for example, we talked about the brainstem. If that part is impacted, it's going to also create potential cardiovascular issues, right? So if you have patients who have, this massive response of epinephrine because of a significant injury, you're going to also see cardiovascular concerns. And penetrating injuries, always an issue. I forgot the guy's name. It was like Phineas Gage. I think it's Phineas Gage. He took a railroad tie right to the front of his head, somehow survived, but went from being a really nice guy to being a really nasty guy. All right. Head injury patients like vomit a lot due to increased intracranial pressure. So airway needs to be of utmost concern. And if you are like, I'm not sure I'm going to intubate this patient, make sure that you position them appropriately. New York City protocol wants you to keep the patient end tidal between 30 and 35 if there is evidence of herniation, which would include posturing. All major bleeding, obviously, control appropriately. You want to maintain an adequate blood pressure, but you also don't necessarily want to overdo it. This is one of those situations where permissive hypotension might be appropriate. We talked about memory status already, right? See if the patient has any level of amnesia. What kind of medical history, medications, right? Those patients with blood thinners are going to be a big concern for you because they're potentially going to have difficult to manage internal bleeding. Mechanism of injury, always important. Motor skills, right? Follow commands, level of consciousness, GCS. Always check pupils. Pupils are great. The human body has this really kind of weird thing that it does. It will actually look at where the brain bleed is. So if you have a person who has, like maybe they got hit in the head and like bystanders like, I don't know, I couldn't see where they got hit. They just kind of crumpled. If you check their pupils, if they have what's called the gaze, they'll actually look at where the bleeding is. Their pupils will directly look. So they might be looking straight up because the bleed's like right here. They might be looking off to the side. It's pretty wild. I don't know. Your brain does some weird. The human body does some weird things. About 1 millimeter of difference between the two pupils is normal. Anything larger than 4 millimeters is considered dilated. But it's also important that you understand if the patient is on some sort of drug also, okay, right? If they're on like cocaine or something and they have a head injury and they have dilated pupils, it might be secondary to the cocaine. So, try to get a full picture. Any decrease of 2 points with a GCS of 9 or lower is indicative of a significant injury. Any decrease of 2 points of GCS anywhere is significant, right? So you might have a patient who's like, you get there and they're like, hey, yeah, no, I'm not feeling great. I hit my head. And then their GCS is 15, and like 5 minutes later, they're like really confused. They don't remember who you are, even though you've been with them for 20 minutes, and you're hanging out and going to the hospital. That is a progressing injury. Okay, that needs to be a note. That needs to be something that you bring to the hospital's attention. And we talked about this already, right? If the patient is not, is hypotensive, you should correct that, but you should abide by permissive hypotension because you don't want to increase cerebral edema in a patient with head trauma. Do not hesitate to control seizure activity, right? Midazolam that patient so they don't seize, because every seizure increases the hypoxic state that the patient is going to be in and will create a worse outcome for the patient. Be careful when you're managing hypoglycemic patients with head injuries. Okay, you don't want to. Again, sugar is just as irritating as blood is. Now, sweet blood is going to be very, very irritating. So you don't necessarily want to, the New York City's protocols, you're still using D50. You don't necessarily want to overcorrect a patient who might be a little hypoglycemic. You want to make sure that you're, doing best by the patient. GCS 9 to 13 is usually a moderate TBI, 8 or less intubate, and it usually is a significant TBI. Make sure that you also do a full-blown assessment and treatment, right? Because if you have a hypoxic patient and you correct the hypoxia, maybe their head injury is not as significant as it was before. Revised trauma score is a useful tool that we don't very frequently use in the field. This is very commonly seen when you get into the ER itself, where they start to try to predict how well the patient's outcome is going to be. If the patient has a score between 0 and 12, anything less than 11 should be considered going to a trauma center. But again, it depends on your system, where you're working, and what the patient's overall vibe is. How we doing?
Live.
All right. Take 5 minutes, stretch, get some more coffee. I'll see you back in 5. How are y'all doing? Did anyone actually get coffee? Because I need coffee, and I need to live vicariously through someone who's had coffee. Damn it, Andrew. He's got my water bottle. They break things. Alright, we have one left. It's relatively short. It's chest trauma. Waiting for a few more people to pop back up. We're on fire now. Alright.
Nicole,
Yes.
where would I find this information? A properly managed medical home patient, what would I expect to find?
I'm going to have to look in the textbook and tell you where to find that exactly, but I'm going to say it's probably in the patients with special needs.
Special needs?
Yeah, like the chapter where it talks about the patients at home who have like the vents and the accessories and all that jazz. That chapter.
Okay, thank you.
You're welcome. All right, cool. Here we go. Chest trauma coming up. Coming in hot. All right, so the thoracic cage, right? Them ribs, they're very helpful in protecting all of the vital organs that we have in the middle of the chest, right? So we've got your your lungs, you've got your heart, your liver happens to appreciate a little bit of protection, as does your gallbladder and pancreas on that that upper echelon gets a little bit of love. Your kidneys in the back also get a little bit of protection from those floating ribs. The magic of your rib cage is that it helps you breathe, okay? It provides the bell jar structure of your chest so that when your muscles pull against it, they expand, and then your negative pressure breathing system or respiratory system, right, actually inflates, okay? You have two clavicles, right, that not only help suspend your arms, but also end zone 3 of the neck. So once you get past your clavicles, you are officially in chestal regions. In between, you have 12 ribs. In between each rib is your costal cartilages, okay? There's little muscles in between as well. Your sternum, right? It chills right in the middle there. Our biggest concern with the sternum is when we do the pushies on it for the CPR. You have what's called false ribs. They're called false ribs because they do not independently articulate with the sternum. They articulate with this cartilage magic that then pulls them up. The bottom two ribs do not articulate with the sternum at all. They're called floating ribs. So your sternum is consistent of the manubrium, which is up top, right? That little like kind of chest plate vibe. That helps to create your jugular notch and your sternal angle, which is like that little indent right there, right? So your clavicle articulates with the manubrium up high. And then you have the actual body of the sternum, which is the part that we put our hands on to do CPR. And then you have the very bottom, which is the xiphoid process, which is a little bit pointy, okay? This is why when we do CPR, we don't want to push on the xiphoid process because it's pointy and you can just jack everything up that's underneath it. Your clavicles attach up top to that manubrium, and then they stretch across to your arms. speaking of clavicles, they are the most frequently fractured bone, okay? They're kind of gently S-shaped, and they're not a great shape. They don't transmit energy well. So anyone who trips and falls and lands on their arm, that energy gets transmitted all the way up to the clavicle, and that's usually what goes crack. Very, very frequently fractured in children because of the whole trip and falling thing, right? Get a little too excited, trip and fall, go boom. Pain, tenderness, obvious deformity, okay? There's definitely patients you're going to encounter who have just like one funky looking clavicle because maybe they broke it and they never got it fixed or it healed funny. Traditionally, clavicles are not a really significant injury, okay? It's relatively isolated because it is such a fragile bone. Rib fractures. Rib fractures kind of happen on the lateral aspect. So this is why we do CPR the way we do, because if you compress the chest in an anterior posterior fashion, the ribs are shaped like this, so they can do that, right? It's like a C shape, and they do like a spring kind of vibe. If you take a C shape and then you go this way, which would be the lateral direction, they break. Okay, their chest is not designed to be compressed this way. I gotta go back to my little picture. So very commonly occurs in adults. Remember, we have hard bones where kids have those spongy rubber bones. As you get older, your morbidity and mortality increases because now you don't have that same respiratory reserve that you did when you were younger, because you have to recruit all of the ribs in order to get a good breath because your vital capacity decreases. Rib fractures are very painful, okay? For the most part, patients will be able to tell you exactly where it hurts, and you will potentially feel crepitus. The problem with rib fractures, especially in the older patient, is that they won't take a deep breath because it hurts so badly, okay? So you're going to have potentially respiratory compromise if the patient has rib fractures. Boop. There we go. So your first and second rib, your clavicles actually live right on top of your second rib, or your first ribs kind of float right above it, okay? So it's very unlikely for the first and second ribs to be affected, okay? They are very well protected. If you have a patient who is complaining of like a pain up and they have the clavicle might be broken, which would give you an indication that perhaps the ribs underneath are also broken, right? Significant mechanism of injury, etc. Patient may also have bronchotracheal injuries, right? So this might be a patient who you see subcutaneous emphysema with. This also might be a patient who has a myocardial contusion, right? So you're going to want to do an EKG and a 12 lead on them. You also want to make sure you also might want to make sure that you consider that the mechanism of injury was so significant that there are going to be other injuries that are not necessarily noted. Flail chest. I think this is a video. It is. Oh, son of a monkey. That's your flail chest for anyone who's never seen it. A flail chest is two or more adjacent ribs fractured in two or more places. Okay, so it starts to create what's called paradoxical motion. You may not ever see this paradoxical motion because remember, your body does this really nifty thing called self-splinting. The muscles will spasm and it will keep those ribs in place. That spasm can last for about 2 hours. So if you're, on the scene within 20 minutes or 10 minutes, right, a good 911 person, you might not see that paradoxical motion because those muscles are in such a spasm. However, once that spasm starts to subside, you'll see that really significant paradoxical motion, which will then create decreased ventilatory effectiveness. They keep changing the way they want the flail chest to be managed. At one point, we were putting like sandbags to protect the chest, and I think now we just kind of leave it and hope for the best. Let me see. So flail chest, because of the significant amount of motion in the chest wall and the ventilatory problems that it creates, has a pretty high mortality rate. Also, it creates, there's a significant amount of trauma and like significant MOI that will create a flailed chest. Okay, it's like they're taking this patient's body is taking a pretty big hit, so they're probably going to have pulmonary contusions. They might have a myocardial contusion. They might have liver or spleen injuries because of a pointy bone parts protruding into those organ systems. The most important thing that you're going to do is, if the patient does have respiratory compromise, that you're going to obviously assist ventilations. If you do suspect that the lung is damaged underneath, you're going to decompress. Right? You don't have to necessarily wait for the patient to be in tension pneumo before you decompress. Okay, this is a significant mechanism of injury, high index of suspicion for that pneumo. Sternal fractures are also pretty hard to accomplish. They are very rarely isolated injuries, okay? Most of the time it's due to a direct blow to the chest. Most of the time something like a steering wheel, right? If you actually look at the image right here, that dent in the sternum was created by a steering wheel. The problem with that is, now if you have this isolated direct pressure, you're going to have a lot of damage to everything underneath. If you've ever done CPR, you know that you push on the sternum to compress the heart. So you could have significant contusions to the heart. You could have cardiac tamponade, pulmonary contusions, pneumothoraxes, a lot of other serious injuries as well. This is one of those patients who you're probably not going to be super concerned about just the sternal fracture, because they're going to have significant injuries to other body parts as well. Most of the time, pulmonary contusions are related to deceleratory forces, right? So you're kind of crushing those lungs and potentially also the heart up against the chest wall. In the lungs, all those alveoli sort of burst. And remember, those alveoli are very thin. On the other side of the alveoli is a very thin capillary. So you start to have blood filling up in the lungs. It tends to be a very significant injury. Pulmonary contusions are pretty significant. A lot of hypoxia. Patient will be potentially very anxious. They might be coughing up blood. There's a lot of considerations, right? You might need to ventilate this patient. You might need to end up tubing them so you can actually get some of the blood out of their airway. Pneumothorax can be caused by spontaneous. It could just all of a sudden the lung just goes, poof. It could be caused by a fractured rib or pressure wave, right, due to either a closed pressure against a closed glottis, like a car accident after someone who's taken a deep breath, diving injuries, etc. Or it could, as I said, just be spontaneous. If it does proceed into a tension pneumo, it starts to become more deadly. If it also has a hemo component, it becomes more deadly. If the tension pneumothorax starts to occupy more than 40% of the chest, the patient will likely die. That's a very poor outcome, especially if it's not managed. Open pneumos are equally as concerning, less because of the possibility of a tension pneumo, because now the air has a way out, but this sucking chest wound increases or creates a new hole for this oxygen to enter. So instead of you having a tension pneumo because you have an intact chest wall and you're bringing air in and it's leaking out of the lung, as you take a breath, the air is coming into the chest through this extra hole and not making it into the functional portion of the lung, which increases hypoxia, increases anxiety, and is just troublesome. These are the kind of wounds that you're going to be managing with an occlusive dressing. Tension pneumo. Okay, so tension pneumos are kind of on the rarer side for you to see. Again, this is sort of like you're waiting, the same kind of concept where you wait for the flail chest spasm to go down. For the most part, the patient if it won't start developing a tension pneumo until a significant amount of time into the injury. So perhaps you might see it if you have a patient who fully ruptured their lung, okay? Or you have somebody who had a simple pneumothorax like 3 days ago, and they, because they, maybe happen to have a weak spot in their lung, and they keep breathing and breathing, and they start to actually accumulate that extra pleural space air. In the event of a tension pneumo, what happens is the air starts to crush the good lung and the heart, and that increased pressure also starts to compress the vena cava, which means that there's not as much blood returning to the heart to get to the rest of the body. So you have a patient who not only has hypoventilation, but they're also hypotensive, and they are going to start to see that going to start to see the tracheal shift, and the tracheal shift is going to go towards the good lung as the tension starts to build and go across from the bad side to the good side. This is one of those patients who you're going to want, if you do happen to see all of these things, you're going to need to decompress the patient in order to kind of alleviate some of that pressure. We use a 14 gauge needle. It's relatively effective for the emergency setting, but this is the kind of patient who's going to need a chest tube, okay? The 14 gauge only does so much. So here's a little better visual of how a tension pneumo works, okay, right here on the end here. That increased space, and it doesn't always have to be an open space. This just makes it happen faster. This air starts to get trapped, and it starts to push everybody over and compress everything. Open pneumos just have a collapsed lung. Again, this is a patient who needs a chest tube so they can reinflate the lung. And same with a closed pneumo. It's just a matter of the atmospheric pressure that's creating the issues. In the event that you have a patient who has penetrating trauma, the first thing that we always say, make sure you do an occlusive dressing. The problem with that is now you're removing that extra route for the air to escape, and you're going to increase the likelihood of a tension pneumo. So if you do happen to have a patient who, you've sealed up an open chest wound and now they're having a harder time breathing, we burp the dressing. So you might remove the dressing for a period to release the tension and then reseal it. You could also insert a needle decompression site in the event that that's a concern. When doing a needle decompression, you're always going to insert it mid-clavicular over the third rib in the second intercostal space. So it's right below the clavicle, right? You're going to feel for the rib. You're going to palpate the top of the rib, and you're going to insert the needle just above that. The whole concept is that you have neuro and vascular tracts right underneath the rib. So if you put it on top of the rib, you'll preserve that vasculature and the nerves. There's some services where you can actually insert the needle decompression in the mid-axillary region, but in our area right now, it's just mid-clavicular. And here it is. Second intercostal space, mid-clavicular, over the inferior rib. So let me go a little pen. All right, so you have your first rib. Here's 1, here's 2, and here's 3. So your intercostal space is right here. So because we see here's the vasculature, right? It runs right underside of this rib. You're going to take the needle and you're going to insert it just over the third rib into the second intercostal space. That's going to keep you from hitting any of these important structures on this side here, which exist on both sides, right? And will hopefully also alleviate the pressure. The idea of going in the mid-axillary region, so here's 3, here's 4, here's 5, is that if the patient's lying supine, that's where the air will potentially accumulate.
And the mid the clavicle, that's you can count that as the second rib and then go down from there.
Yeah. It's the first rib. Sorry, I misspoke before. It's the first rib. So your clavicle is the first rib, and then you should have your second rib, and then your third.
It's hard to palpate for me though.
It is. It's hard to palpate. It's easier if the patient is lying flat, and it's easier if they're very, very thin. Um, you might not be able to palpate the your anatomical region on a larger patient. I mean, I had a guy once, he was like 6'5", 350 with a tension, and I didn't decompress him because I couldn't find the right location. So he had to wait to get a chest tube.
There's no rule of thumb for this?
No, it's all about palpation, unfortunately. Go. All right. Hemothorax, right, is an accumulation of blood. Each side of your chest can hold about up to 3,000 milliliters of blood. So if you think that as a larger sized normal standard adult, and by larger size I mean male shaped, you have about 6,000 milliliters of blood. You can essentially empty your body's blood into your chest space. You're displacing the lungs, obviously, in order to do so, but it's a good storage unit, I guess. The problem now with a hemothorax is that you have hypovolemia on top of hypoxia, right? Because that lung is getting displaced by blood, getting smushed, so you're reducing the vital capacity, and you're also losing blood at the same time. Traumatic asphyxia is probably one of the most wild things that you're going to potentially ever see. Most of the time is caused by a severe crushing injury to the chest and or abdomen. So as that pressure starts to increase the intrathoracic pressure, it forces the blood back to the neck and the upper part of the body. So you'll have a patient who, from wherever the crush injury occurs, everywhere above it will be deep, deep purple red, okay, because of the increased blood flow, because it's starting to back up from whence it came. You'll also have, the patient will also be very hypoxic because they're not going to be able to expand their chest appropriately, obviously due to the weight of whatever's crushing them. These patients will present with JVD. I think the bigger potential sign that you're going to see is the fact that there's something laying on their chest. Myocardial contusion, very commonly associated with patients who strike their chest against the either dashboard or their steering wheel. And it's a bruise to the heart, okay? It may or may not result in a cardiac tamponade. Most of the time it's just kind of isolated to the injury itself. It may present as a STEMI because of the bleeding into the muscle itself. So you might have cardiac irregularities noted on your EKG. And this is why we do a 12 lead, especially on unrestrained patients, but on patients who have sustained some sort of chest injury during a car accident. There's also the possibility that the myocardium may rupture due to the blunt force injury, and that's going to be a bigger problem than just the bruise. Myocardial contusions can be pretty lethal if they're not managed appropriately. Pericardial tamponade, okay? The blood or any other fluid that doesn't belong there can actually start to surround the heart and crush it, okay? Remember, this pericardial sac is very fibrous, it's very thick. It usually has about 10 cc's of normal fluid living within it to reduce the friction of the heart as it pumps and swings back and forth. Some sort of trauma or infection, because sometimes it's an infection, but because we're talking about trauma, we're going to discuss trauma. So some sort of trauma creates a tear in the heart wall, which then creates that leak of blood into the pericardium. It's not able to fill up with a significant amount of fluid. It's only about as much as 100 milliliters, but that can diminish the cardiac perfusion significantly and result in all sorts of issues. Let's see if I have that. I do. So this results in Beck's triad, which is a combination of JVD, right? So because the heart's not pumping effectively, the blood comes back from whence it came, which is from the head and the rest of the body, so you'll see JVD. Upon auscultation, you'll hear muffled heart sounds because now you're pretty much putting a big fuzzy blanket of blood around the heart, and the patient will be hypotensive. The patient will show electrical alternons, which, Danny, this is your thing, right? So you'll have one normal-sized QRS followed by a small low-voltage QRS. Okay, that's what the kind of the hallmark sign on the EKG of a pericardial tamponade. You will also have pulsus paradoxus, so if the patient takes a deep breath, you will notice that you will potentially lose a radial pulse, or the systolic blood pressure, if you happen to be taking blood pressure during that time, will drop significantly because it's increasing the pressure on the heart. You will also notice what's called a narrowing pulse pressure, which means that the difference between the systolic and the diastolic blood pressure gets closer and closer. So, for example, the normal blood pressure is 120 over 80. There's 40 points of difference between 80 and 120. A patient who has pericardial tamponade might be 100 over 90, okay, because the pressure is not able to be, because of the pressure on the heart, the internal pressure of the diastolic isn't able to relax, so that number starts to climb up, which means that the heart isn't able to refill effectively, which means you're pushing less blood around the body. Myocardial rupture, we talked about this, right? There is a significant pressure on the heart which causes it to go kaplooey. Almost always fatal, very commonly seen in car accidents, especially in patients who are not restrained, or direct compression of the heart, right? So instead of having a patient who has a traumatic asphyxia, they might just be compressed to the point where their heart actually explodes. Myocardial rupture can also be secondary to a myocardial contusion, which we spoke about. And it also can be secondary to a patient who's having an MI, depending on what area of the heart is affected. If it's significantly ischemic, that part of the wall can become so weak that it actually can rupture. Most of the time, though, in the traumatic incidences, it's caused by significant deceleration and or shearing forces. We talked about this already as well, right? So we have that where the ligament attaches, which during a high deceleration force starts to shear the aorta. Again, high-speed motor vehicle accidents, falls from heights. Again, this is going to be your traumatic arrest. This is why, this is what happened. The patient, had a significant aortic rupture and they bled out within 2 or 3 heartbeats. It's caused, remember we talked about this before, the ligamentum arteriosum, that's what pretty much just rips the aorta open as the shearing forces move the heart dramatically. These patients might have hypertension up in the upper extremities and cold, pale lower extremities due to the fact that the blood's not making it all the way down and around. You will, just like you would see in a thoracic aortic aneurysm, differences in the blood pressures from left and right arms. And you have a patient who might have a level of paraplegia without actually having any spinal injury because there's such significant hypoxia below the site of the aortic rupture. Penetrating wounds. If the great vessels are involved, it's traditionally the penetrating wound is the chest, abdomen, or neck. Occlusive dressings, right? Always important. Depending on what part of the neck or the body is actually penetrated, will result in what kind of injuries you'll see. So if it's the chest, you might have a cardiac tamponade or a myocardial rupture secondary to being stabbed. You might have a hemothorax if it's on the, more on the side of just the lungs. You could have large hematomas. You could have air embolisms if it was a stab to the carotid up top. So again, your main course of action is to stabilize this injury. If this weapon, make sure that if it is not actually full of a weapon, the wound is occlusively addressed. Esophageal injuries, kind of more on the rare side, but as we talked about in one of the last lectures or last slides, it can happen. It can be caused by not only like anatomical changes or distortions caused by cancer or GERD, but it can also be caused by penetrating trauma, very rarely by blunt trauma. A lot of the times, patient will have a difficult time swallowing. Again, these are not things that you'll necessarily see in the field. The patient will most likely have a more significant airway injury or spinal cord injury, depending on which direction the insult happened. That will probably be distracting over the esophageal injury. Tracheal bronchial injuries. Okay, we talked about this previously with the subcutaneous emphysema. Relatively rare, but in the event of it happening, you will have a significant amount of subcutaneous emphysema, difficulty breathing. The patient might be coughing up blood. They might be severely hypoxic depending on what part of their tracheobronchial tree was affected. Commonly, penetrating injuries are more common up top because people like to do the stabby stab up high, whereas blunt injuries are usually associated with like car accidents, etc. So it's commonly more low in the areas where may strike a steering wheel or a seatbelt comes across. Diaphragmatic rupture. We talk about this when we talk about pediatrics, right? When they have a poorly formed diaphragm and their abdominal contents go up into the chest. This can also happen in the event that an adult patient ruptures their diaphragm. Most of the time, this is caused by abdominal compression that causes everything to go up and then just breaks, ruptures that diaphragm. You may have gastric sounds on the left side of the chest. You might have a difficult time ventilating the patient. Patient might present as having like Beck's triad, where they have hypotension, decreased output, shock, but they also might have what's called a scapular abdominal look, okay, especially if they're a thinner patient, you can see their stomach. It might actually look like they have nothing inside their abdomen, mostly because it's all hiding up in their rib cage. Ah, look at that. Thoughts, questions, concerns? Definitely think I gave you at least one answer. I know we didn't talk about all this stuff. Maybe one or two. All right, cool. Any other questions or concerns before I let you all go for the day? All right, cool. Peace out, Cub Scouts. I'll see you later. We'll try to do another review session sometime maybe this week. So for protocols, just for protocols. Hold on, let me see. Maybe Friday night. BYOB. If no one's doing anything. Let me know, or I'll send out an email and we'll do a quick poll or throw it to the group to just do a one or two cases, do a little review, and have a lovely evening. So other than that, have a good day. Let me know if you have any thoughts or questions. And as of right now, y'all are verified. Congratulations.
Thanks, Nicole.
You're welcome. Have a great day, guys.
Thanks.